I just added to this PowerPoint because Microsoft 365 is terrible.
Hey, Jonathan.
Yes.
The poll, I don't know if anyone else is having trouble, but I can't move it off of like the location of where it is on my screen.
Oh.
Like it's popped up in the center. Can anyone else like move it out of their way so they can even see Jonathan's screen?
So are these not? Maybe this isn't going to work then.
No. Put your Teams as like full screen, and then your meeting chat will move off to the side instead of a pop-up in the front.
Okay, so put it to a full screen, and then meeting chat will move off?
Yes.
All right, thank you.
Let me know if that doesn't work, then.
I'm sure there's an easier way to do this, but here I am. All right, so for those of you who weren't here earlier, when I was talking about this, we're going to start with a mix of anxiety and depression questions / farm. You guys should be able to answer all of them. And then we'll go into a brief refresher of like the brainstem thing that we drew yesterday, and run back to the spinal tracts in like 30 seconds. And then we'll start doing some lesions with the spinal tracts. And then I found some actual questions from Amboss. UWorld was just like down yesterday, I guess. I don't know. That you guys should be able to answer. And are pretty good examples of the types of questions that they ask in the exams. So, all right, I get a minute per question. I don't know if I have to put a new poll up. Okay, so you can just change your answer in the poll, and it will show the new answer at the bottom. And I pinned it, although maybe that made it worse. Oh, I pinned it. Now it's just gone. All right, well, does anybody have an answer for this one? C. Yes, it is. It is C. They love, like I said yesterday, they love to do this. They'll like emphasize that the kid is talking to somebody who's passed away, or even seeing them, or hearing them, or doing things with them, and it's completely normal in kids up to a year. That one should be at the bottom now. And we should just be able to roll with that. It looks like everybody is saying D. Why is someone who said D? Why? Chat's gone. Anybody? Anybody with a voice? We're all friends here. There are no wrong, no stupid answers.
Is it because he's been feeling this way for more than since his girlfriend broke up with him 4 years ago, and he's been having these moods of like where he feels depressed and for like lasts for a month, and he has the depressed mood and affect?
Yep. What else is this called? What's the other name for this?
Dysthymia.
It is dysthymia, and that's usually what they call it on exams. Is dysthymia. They usually don't say persistent depressive disorder. Wait, let me rephrase that. Block exams usually say dysthymia. NBME usually says persistent depressive disorder. So you need to know both terms. Also, this is the whole thing. You know, there's not 5 symptoms, right? Like you're not being flooded with symptoms this guy has. He's just like a little bit depressed. Well, a little bit depressed. You guys revote in that same poll, or is it going to make me recreate one every time? I think you can just change your answers. Yeah, okay, so you can just change your answers. Cool, 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 cool. Although it seems like there's still a lot of people who are stuck on the last one. Okay, so this is A. Oops. And the reason why this is A is because you have to continuously screen people for suicide if you think there might be a risk. So sometimes they'll give you like a physician response question, and you don't really know what's going on, but it's obvious this person has a major depressive episode, right? They have a lot of the symptoms, feeling increasingly desperate, right? So this is hopelessness. This is like a big red flag for suicide, suicide risk. And the thing that's important to know is asking somebody if they're suicidal will never in any circumstance increase their risk of making an attempt. So there's no harm in asking ever. So just if it is an answer, like it's not condescending, it's not off-putting. If they have an answer, they probably want you to say it. And the rest of these really, like, this is the whole like paternalistic thing. A lot of these answer choices, which you're just never going to choose any of these. I don't want that to pop up for you guys every time. Yeah, this is A. Right. So it's major depressive disorder. You guys haven't done like the I don't think you guys have done the trauma disorders yet. So I think the military veteran thing is just a distractor. But he has every symptom there is, right? He can't sleep. It's affecting his day-to-day. This is a big one. Losing interest in things that you used to be interested to. They immediately want you to start thinking in the depressive like category of disorders when they say that. It's a big buzzword. Who's got an explanation for this one? This is very important. You guys get a little bit of an advantage because you haven't done any of the like schizophrenias or bipolar disorders yet, but what didn't you do for this patient?
Is this screening for bipolar so he doesn't have like a manic episode?
That is exactly correct. This patient was not properly screened for bipolar disorder. So by giving them lymphaxis, right? This is an SNRI, right? This is the OPP, right? You trigger a manic episode. Usually they're not going to give you venlafaxine. It'll usually be like just one of the SSRIs. But you do this very high yield for psych pharm. Is that SSRIs and SNRIs will trigger manic episodes in a bipolar patient who has not been properly screened. All right, what's he taking? What's the problem? What's the problem, and why is this a nefarious question if you're not in psych? Yep, it is trazodone. But why is this a nefarious question if I wasn't giving it to you in the context of a psych review and I was giving it to you in the context of a comp exam? The answer is because sickle cell also causes priapism. Huge propensity to cause priapism on exams. Oops, I went backwards somehow. The reason why sickle cell is not the answer here, besides the fact that they gave you trazodone, is because the sickle cell priapism usually happens in younger people. And the reason is because the sickle cells obstruct the venous return, so the blood cannot leave the penis, so the erection cannot resolve. All right, starting off. How many of these are antidotes? To things. How many of these can be used to reverse iatrogenic effects, right? I mean, pretty much all of them, right? Atropine, naloxones for opiates, right? You give glucagon if they're hypoglycemic because you gave them too much insulin. What's cyproheptadine reverse? Does anybody know? This is for iron. If you have too much iron in your body. Ammonium chloride, I have no idea. I'm pretty sure this is in deodorant. But the answer, bicarb, right? Because this person overdosed on his TCA. You give bicarb to correct the effects on the heart, right? You're not giving it for an acidemia. You're giving it for sodium levels. This is big. Big to remember.
Ammonium chloride is an amphetamine antidote.
All right, well, there you go. It's an amphetamine antidote. I didn't
Not
know
one
that.
that you're probably ever going to choose as an answer, though.
No, no. All right. So this lady is depressed, and we need to start on a drug, and we have to avoid one of these. Which one are we avoiding and why? It's true. Yep, she has an eating disorder. So which one are we avoiding? Yep. Do not give Wellbutrin, bupropion. Patients with eating disorders. It suppresses the appetite. It's important to notice because I think a lot of people sometimes get this confused. She's binge eating, right? She's binging and purging. So she's overeating at some points. But you're still not going to give an appetite suppressant for any of the eating disorders. Do not give any drugs that modulate appetite like that. You guys seem to get that one pretty quickly. All right, what are we starting her on? Let's see. What's the drug here? Yep, you're starting on Wellbutrin, bupropion, right? It's a stimulant. You'll get tachycardic. QT prolongation, right? This is TCAs. Don't forget. All right. Tender, palpable suprapubic mass, hypoactive bowel sounds, a large anechoic mass in the pelvis. What is this? What is this, and what the hell does it have to do with a psych drug? Nothing? Nobody? No guesses? A tumor? It's not a tumor. It's their bladder, right? So when you give amitriptyline, right, it can cause enuresis, right? So basically, they can't urinate. The anticholinergic effects suppress the detressor muscles. The urine gets stuck in the bladder. It gets really full. You're gonna feel it. You're gonna feel the mass. You're gonna put an ultrasound on there, and it's just gonna be just a big anechoic space, right? Um, Side effect of TCAs, and TCA is used generously here because it's basically always going to be amitriptyline in these kinds of questions. But you gotta really gotta remember amitriptyline for this specifically for urinary retention. All right, we started him on paroxetine. What is paroxetine? An SSRI. Number one side effect for SSRI? Yep. Decreased sex drive, inability to maintain an erection, sex related. The most common thing, they ask about it a lot. All right, so for starters, what's the problem? What is the condition that this person has? Yep, it is a hypertensive crisis. But what's causing it? It's tyramine crisis, which means this is the cheese reaction, which happens with monoamine oxidase inhibitors. So which one of these is a monoamine oxidase inhibitor? Transcyclopromine. I don't know. These are hard to pronounce. Don't make fun of me. But yeah, this is it. They love to ask about the cheese reaction. Really, if you learn anything in BAB, you should really stay away from charcuterie because you're gonna have tyramine crises and you're gonna get listerial meningitis. So it's just bad all around. All right, so we started this guy on SSRI. Sexual dysfunction. What do we switch him to? It is E. You are correct that SNRIs have less sexual side effects than SSRIs. But SNRIs here are bait because less sexual side effects does not mean no sexual side effects. So you switch to bupropion. I made sure to find this question and put it in here. Flat effect. Usually when they talk about a flat effect, they're talking about Parkinson's actually. But it'll be, or like they'll also say like a mask-like face, but it's really like they're really like dry and monotone and like there's no emotion to anything that they do, and they're just kind of like sitting there and like you can't read their facial expressions because they don't have any. That makes sense. Let's get it. But yeah, 100% SNRI, absolute bait on these questions. You switch to bupropion. Oh, is this the same one? Did I put this in here twice? Sorry, guys. Oh, I just went backwards. Never mind. Oh, okay, cool. So that's okay. So that's all the site questions. All right. I realized yesterday there's something important that I didn't mention. What the circle of Willis looks like on scans, because sometimes they'll give you the radiological image instead of like an actual diagram, and you need to know. So this is the angiogram from the bottom, like looking basically like if you were, I don't know, put your head in the person's chest, right? And looked up. Oh, so I guess the normal view, the normal scan view, right? Like the normal CT scan view, right? Which is how we are used to drawing it. So that's why yesterday when I was like, oh, well, the anterior is in front, so it makes sense because, anterior, posterior, right? For ICA and PICA. However, this is not the view. This is not the view that they're ever going to give you on the exam. I just put this in here so you could kind of like sort of understand, I guess, where we're like coming from. This is the view that you're going to get on the exam, usually right here, this one. So I know it doesn't look anything like this. But it is what it is. This is whenever there's like they'll have like a, yeah, that's true. Whenever they have a question, it'll basically, you need to know the orientation of these because it'll say like someone will have like hemiparesis, and you have to know it's like the MCA on the opposite side, right? So like you have to remember that this is the patient's right side and this is the patient's left side, and they'll have right-sided hemiparesis, and you have to know that it's like this is where the obstruction should be, right? Because it would be their left MCA, right? Because it's contralateral. So just familiarize yourself with this. This is the view from the sagittal view, right? So like you have like this is the coronal view. This is the like regular old CT view, and then this would be like the sagittal view. You'll never get this ever, but I just wanted you to be able to kind of see the path specifically that the internal carotid takes when it comes up, because this is where the aneurysms happen, and this is why it impinges on cranial nerve 3. And that's why like the only time that you'll really have a patient that presents with symptoms that you can diagnose like an aneurysm, before it bursts basically, is an internal carotid aneurysm, and it's because of impingement on one of the cranial nerves, usually cranial nerve 3. So the person will get like ptosis. Their eye will be pulled to the side. Yeah, but circle of Willis, right? Super neat to know this. And then a quick recap of these. The rules of 4, right? This is half of the brainstem. Medially, you have multiples of 12, cranial nerve 3, 4, 6, and 12. I believe you guys did cranial nerves today, right? So I can be mean about them. You're supposed to know them. Or is it just the OLMs? It wasn't the Q&A session. Oh, you guys said the clinical medicine case? Okay, so the cranial nerve OLMs are today, and you don't have the Q&As. All right, I won't be that mean about them then yet. But anyways, your 1 and 2, right? They're above the midbrain, but they're sensory. 8 is the other one that's purely sensory. These are all kind of mixed, right? But they're still lateral. For the trigeminal ganglion, it goes proprioception, touch, pain, and temperature. And then the midbrain, laterally of the SCA and the PCA. And then for the pons, it's the basilar arteries, medially, icolaterally, and then for the medulla, it's the anterior spinal artery, sometimes a little bit from the vertebral arteries, but they don't really talk about that. And then pica. The reason they don't really ever mention the vertebral arteries is because they kind of run like in the middle of the lateral and the medial, so it's kind of hard for them to differentiate questions. But if neither of these was an answer and vertebral artery was there, and everything else sounded awful, it would be an acceptable answer. All right, so let's label the circle of Willis. Let's start from the top. And by let's, I mean you guys. You guys are going to label the circle of Willis. So somebody tell me what this is. That's right. That is your ACA. So this is the ACA. What is this? That's ACOM. And what's so important about this space right here that we talked about on Tuesday? Yeah, all right, that's fair enough. Okay, so it allows for bilateral flow. Yeah, okay, so that's correct. So technically, you do get you can get a blood like a further blood supply. So if this is blocked, right, you get blood supply from the side, you won't lose the ACA. If this is blocked, you get blood supply from the side, you won't lose the ACA. However, actually, I've actually seen this. Now that it's funny you say this, I've literally seen this as a question. If the thrombus happens here, you're fine. If the thrombus happens here, you're fine. If the thrombus happens here, you're screwed, because then there's no collateral supply going to the other side. However, that's not really what I was asking. This is the most common site for a berry aneurysm. I've seen that. I've seen them ask about that before. That's it's just something to keep like in the back of your head. What are these? No, you're fine. You're fine. Yeah, I'm sure. Yeah, you thought I was pointing here. Yeah, these are the MCAs, right? But what are these? Yep, those are the internal carotids. Do y'all know what these are? No, not the lenticular striates. Yeah, 1 second. Just. Yep, that's right. These are the ophthalmics. Okay, so basically, I saw a question that asked, I'm trying to think how they worded it, but basically, if you have a thrombus that is distal to ACOM, it's bad. Because if it's proximal or if it's before ACOM, right? Because blood's coming this way, then it can come from the other side and supply both ACAs, both left and right ACA. But if it's past the anterior communicating on either side, like if you have a thrombus here, you're going to lose right ACA. So you're going to lose basically all motor function of your left lower limbs. And if it's over here, right lower limb, sorry. And if it's over here, you lose your left ACA and you lose all motor function contralaterally of your right lower limbs. So the thing is that the thrombus, if it's before ACOM, you're okay. If it's after ACOM, you're losing limb function. Where were we? All right, so we said this was MCA, right? You don't need to know what this is. This supplies like the limbic system, basically. Maybe know that this supplies blood to the limbic system, but I've never seen anybody ask about this. What is this? Yep, posterior communicating. What are these? Yep, posterior cerebral. And then after the posterior cerebral, we have yep, superior cerebellar. What is this going down the middle? Basilar arteries. What are they shooting off? Yep, those are your pontine arteries. What are these? Correct. Ica. And then what are these that shoot down? All the way down? Correct, those are your vertebral arteries. And what comes off the vertebral arteries? It's pica. And then what comes straight down the middle? That's right, that's your anterior spinal artery. Are any of these arteries named for anything other than the specific location where they are in the brain? No, the answer is no. So that means that as long as you can draw this on test day, you can figure out the names yourself. Right? So definitely know this, definitely be able to fill this all out. I do recommend being able to just draw it. I mean, it takes no time at all, as you just saw. All right. Easy points. I feel like this is something that people just like wildly overcomplicate. All right, tracts. I need super participation from you on this one, or it's going to be real awkward. Okay. Do you guys want me to run through the tracks, or can I just start asking questions? All right. You have one tract going down, going from the cortex down through the spine, right? Spinal tract. What is the only thing going down? Motor information. Not this one, it's over here, but okay, listen. I tried to redraw this for you guys so I could have one without the nerve tracks on it, so I could like actually be like sneakier and asking questions and you can just like follow the nerves. But it looked terrible. So sorry, this is what you guys get, the ones that are just drawn on them already. I'm sorry. But anyways, yes. Okay, so again, it's just named as it is, right? Cortico-spinal starts in the cortex, ends in the spine. Goes down, carries motor information to the body. The full pathway, it starts in the motor cortex, moves through the internal capsule, goes down through, this is, remember I was talking about, this is the crux cerebri, right? Goes down, 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 down. Oh, I drew these colors wrong, but it doesn't really matter. Oh no, I didn't. Crosses in the caudal medulla. And then it synapses on what will be the motor neuron, which then goes out through the dorsal horn down to wherever, right? Corticospinal tract. Dorsal column. It's in the back, right? It's shaped like this. You have your G for ground, graciculus, and then the Q whatever, cuneatus on the side. Maybe I should put this, right? So, oh. All right, so this is the important part you need, right? So just top section, right? Graciculus, it's medial, right? So this is your proprioception, vibration senses. It's all because if the tracks aren't sending a signal directly to make a movement, they're sending inhibitory signals, which is why you get the distinction between upper and lower motor neuron injuries, and you get like spasticity if you get upper motor neuron injuries, and you get paralysis if you get lower motor neuron injuries. Did you guys do upper and lower motor neuron injuries? Because it's a lot easier if I can talk about that also. Actually, you know what? It doesn't matter. I'm gonna talk about it anyways. Maybe I'm teaching you guys something. I don't know. Okay, so upper. Yeah, you learned about them. Sick. Okay, so quick refresher. Upper motor neuron injuries is anything that's not the like terminal motor neuron. So anything above it. So what happens with upper motor neuron injuries is you get things like spasticity, hyperreflexivity, because you lose all the inhibitory signals, and then you just have like reflex pathways left, basically. So someone basically had explained it before, like when you lose the signals from the brain, mom and dad are away, so the kids are hyperactive, right? So upper motor neuron injuries, anything except for the last neuron, right? So anything, this is in the wrong direction, but anything basically before the nerve body that is in the ventral horn of the spinal cord is an upper motor neuron injury, and you'll have spasticity. Lower motor neuron injuries is like the final nerve that's intervening like basically directly onto the muscle fibers. So that's anything from the axon body in the ventral horn down the limb. Lower motor neuron injuries, you get paralysis or weakness. So you'll have things like muscle wasting. Does that make sense to everybody? It's a really big thing that you absolutely need to know. Absolutely need to know that. Okay, cool. So anyways, what was I saying? Oh yeah, okay, so the graciculus, right? Oops. Right. So this is two parts. You have the G in the middle. This is your legs. The side is the one, the cuneus or cuneatus or whatever it's called. This is laterally. This is for your arms. Right, so this goes to your arms. This goes to your legs. Proprioception, fine touch, vibration senses. This is the dorsal column sends signals to the brain from the sensory receptors, right? So it's going up, it's an ascending tract. and it decussates in the caudal medulla right here, at basically at the same level that the corticospinal tract decussates. But it's more dorsal. It's more dorsal. Then you have the last one is the spinothalamic, right? Spine, thalamic, thalamus. Sensory signals get processed, go through the thalamus, right? Spinothalamic. It's an ascending tract. It crosses, they say immediately, but as we talked about with Broad-Séquard syndrome, it's really like a couple vertebrae up, right? But either way, it comes in through the ventral horn, and then it synapses on an axon body and then, or a neuron body, and then that neuron body projects axons out the other side and straight up the spinothalamic tract to the brain, where it terminates on the thalamus, which then sends signals wherever it needs to send signals. Right, so those are the 3 tracks. Okay, so as long as you remember that pain and temperature crosses immediately, and the other 2 cross in the medulla, you're usually good to go on these questions. Okay, so let's say, and we're just going to talk purely, we'll just say okay, so if I put a lesion, an anterior cord lesion, I'm going to draw this out so you guys can, okay, so you have an anterior cord lesion, unilaterally on the right side at, like, I don't know, let's say T6. What are the patient's symptoms going to be? What are they going to lose and where? Pain and temp. All right, so you said pain and temp left, but then you said IPSY. IPSY what?
Okay, so I'm
It's
having
much easier if
trouble.
you guys talk. Yeah, please.
Yeah, sorry. Okay, so I know that the anterior is telling me that it's obviously not the dorsal, which
Yep.
Means that this is the lateral spinothalamic tract, which is the pain and temperature. And so my thought process is, you're telling me that it's on the right side at T6, but I don't know whether it's at the DRG. I don't know whether it's at the horn. I don't know whether it's at the ventral commissure. Like,
Okay.
I know if it crosses at that ventral commissure, then I'm going contra. So would it be IPSY and stay on the same side, the right side, or would it go to the left?
Okay, so we'll walk through this. Okay, so let's just assume it takes everything from the middle, right? It's just this whole area, right? This whole thing. Hypothetically, if we're saying it's affecting the anterior commissure, you will lose bilateral pain and temperature at T6. But only at T6, because that's where the cross is, right?
Yeah, it'll be focally.
Right. So then below T6, you will lose contralateral pain and temperature, but you'll retain the right-sided because all the fibers that are under T6, so T7, T8, T9, right, more or less, except for the like weird little couple jumps, right, will have already crossed and will be ascending on the left side of the patient's body and will be unaffected by this lesion.
Okay. All
and
right,
then what about
so
motor?
Let me so my motor though is the motor not going to be fine because it has nothing to do with the medial?
Well, and you got to remember anterior cord injuries, right? So like we're not in the brainstem anymore. Now we're in the spine, right? This is T6. So where do the motor tracks run through the spine?
Through the dorsal column?
No, the motor tracks run anteriorly in the spine. The only thing that runs through the dorsal column is positional sensation, vibration, and proprioception. Motor, pain, and temperature run in the anterior portion of the spine. And I don't know, do I have? I guess I don't have them here. Yeah, see, so here. This is the corticospinal tract, right? Like this is the anterior portion of the spine.
Okay.
Yes. Yeah, corticospinal. Yeah, it's motor. So it's here. So now it's true in the brainstem, if you look, right? So motor comes down through the cerebral peduncles, which is like the crux cerebri, right? Which is on the other side of the substantia nigra,
Okay.
right? And then it comes basically down almost to like the olives, right, in the ponds, and then it goes to the pyramidal tracts, right? And it comes out. But yeah, but the lateral corticospinal tract, no, it's in the anterior portion of the spine. The only thing in the dorsal column is proprioception. Yeah, I'll post a recording. The only thing in the dorsal column is position, sensation, vibration, fine touch.
Okay.
All motor and pain and temperature are anterior, and that's why we go back to.
And they're also going to be lateral, anterior, and both will be lateral.
I'm sorry, say that again.
They'll both be anterior and they'll both be lateral, or no?
So you have the Let me try again. Motor is here.
Yep.
Ish. Pain and temperature is here. Ish. It doesn't really matter like specifics because they're never going to ask you. They're never going to be like. They're never going to give you a little circle and you're going to have to guess what it's hitting. It'll be very obvious.
Okay.
So usually they'll separate.
So hold on, Jonathan. So let me make sure I got this part right. So the motor neuron is considered more anterior rather than, or more ventral. Yeah, anterior rather than posterior.
100%. The only thing posterior is the dorsal column, which is position, vibration, fine touch. Yeah. And the reason why, I guess you can think of it this way, those regions are all supplied by the anterior spinal artery, blood supplied by the anterior spinal artery, whereas the dorsal column has the posterior spinal arteries, right? Or vertebral arteries or whatever they call them, right? So like it's a blood supply thing. So these are always lumped together. Everything in the anterior column is lumped together, and it's really like everything that's anterior of the gray matter.
Okay.
Right. So then motor. Is motor going to be ipsilateral or is it going to be contralateral?
Okay, so it's going to come down. It crosses at the medulla, so it went over. So I think that it's going to be contra would be from the cortex down, and it crossed at the medulla. So it would be the ipsi side going down. Oh shit, I don't know.
Yeah. It would be ipsilateral. It would be ipsilateral because T6 is below the rostral medulla, or the caudal. I keep saying that, the caudal medulla. So it will have already crossed. So it'll be ipsilateral to this lesion. Oh, X, and then that side will be fine, right? So what you really have is you have contralateral loss of pain and temperature, ipsilateral loss of motor below the lesion, and then your positional sensation's fine, right? These are the things that you need. These are the types of things that we super need to be able to do. Okay, so what if we did it the other way and I told you that so proprioception and vibration, pain and temperature, motor. Okay, so what if I said that somebody had, oh geez, I should have wrote these out because this is really easy to just absolutely just mess myself up. See, it's hard because you don't really get. All right, assuming that somebody has a problem in the cervical area, right? So like, just say C4.
Okay.
Actually, no, we should go in the midbrain. We're gonna do one in the midbrain, and then we're gonna go to the actual questions. Okay, so assuming someone has a lesion in the midbrain. And they lost pain and temperature sensation on the left side.
Okay,
if I
so
tell you that someone has a midbrain lesion and they've lost pain and temperature sensation on the left side, what do you expect their motor function to look like?
midbrain. Okay, I expect their this is a lot harder than trying it the other way. Okay, so
It is a lot harder.
Yeah,
That's the point.
this is good. This is good. Okay, so I know that this pain and temperature is. Do I need to correlate that with also being anterior as well as the same location as the motor with that more?
So when you're thinking spinal tracts, you don't need to think the motor being medial and the sensory being lateral is really more of a cranial nerve in the brainstem specific thing.
Okay.
Whenever you're talking about spinal tract loss, you're going to assume that you just lose the whole any spinal tract that's running through that section of the brainstem is going to be affected. And when I say that section, I mean like basically everything below. So you can just count left and right side, right? So if you have a lesion in the left brainstem, this is like Brandon said, this is before it crosses over when the signal is coming down, right? So
Right,
that means you're going to have contralateral loss of motor,
Okay.
but you'll have ipsilateral loss of pain and temperature because it already crosses the bottom. That also means, will you have contralateral or ipsilateral loss of position and vibration senses? Anybody can answer. Why do you think ipsy? Why do you think contra? Just because I ask for a reason doesn't mean I think you're wrong. So first of all, we're always talking in relation to the lesion, right? So if the lesion's on the left midbrain, so ipsilateral would mean that you lose left proprioception. Contralateral, I mean you lose right proprioception, right? It hasn't crossed yet at this point, right? Because it crosses in the caudal medulla with motor function. So you would lose contralateral proprioception with a left midbrain lesion. Does that make sense?
Yeah. If we're gonna have to keep doing it though.
That's all right. The best way to do this is suppression. Okay. What happens if you get a right internal capsule lesion?
I think the left side's not gonna work. I think it'll be a contra.
Contralateral what?
Contralateral. Contramotor. What do you mean
That-
contralateral what?
That's correct. You will lose contralateral motor function. What about pain and temperature, somebody? Nobody? Nothing for pain and temp? Nobody has an answer?
They're typing.
What about position and vibration? Are position and vibration affected? Yep, they're both normal. I'm just bullying you guys. Internal capsule is only motor function. There is no pain, temperature, anything like that. So now instead of saying right internal capsule injury, what if I told you this person had a left-sided lenticular striate stroke?
Oh, wait, sorry. Quick question on the other one.
Of
I didn't
course.
quite get how we knew which side was affected with the
Okay, so
when it wasn't right. Yeah.
yeah, okay. So if you have a right internal capsule injury, you'll have a contralateral loss of motor function because it doesn't cross over until the cauda medulla. So then the left side of the body will be paralyzed because the only information that goes through the internal capsule is motor. It is motor only. So if you see in a question, somebody has only motor symptoms and proprioception and sensation are intact, and they have only motor symptoms on one side of the body, and it's hemiparesis, it's basically always going to be the internal capsule because you're losing all of the motor input from the cortex. If it's specific to like just the limbs, it'll be either ACA or MCA usually. MCA for most of the body, upper body, but like it also kind of affects the legs, and like they usually have like some type of aphasia. Usually when they ask those questions, it'll be an ACA stroke, and it'll only affect the legs. But yeah.
Okay.
So
Okay, I follow with that. So just to clarify, so you specifically did say right internal capsule. So was
yeah,
that, but you said it's just contralateral
it's
because it
contralateral.
didn't cross. Okay.
Yeah,
All
because it
right,
crosses
thank
in the
you.
medulla. Of course. So all right, so left lenticular striate stroke. What's the person's symptoms? We'll do like 2 more of these, and then we'll go to actual questions, and then we can loop back to these if you guys want. What do the lenticular striate arteries supply blood to? It's the internal capsule, right? It's just another way they can ask the same question, right? So if you have a left lenticular striate stroke, you're going to have contralateral, so right-sided hemiparalysis, right? So it'll be on the right side, loss of right-sided motor function. They're more likely to ask you this. Does this affect the face? That's a great question. Yes. Yes, it does. Yes, it does affect the face. So here's the thing. There's a couple different ways you can get facial paralysis. It can be locally, like a local lesion in the cortex. It can be a lesion in the it'll usually, if they're asking about the face, it'll almost always either be a local lesion in the cortex, or it will be a lesion in the pons. Pretty much, if they're ever asking about facial paralysis, it'll be cortical or lesion in the pons. What else? What else? What else? Okay, what happens if you cut a dorsal root ganglia? Right. So let's say you cut like I don't know, L4 DRG. True. Yep. Where though? Yep. Focal. Yep. Just right there. Right there. Not below it. Not on the just right there. All right. Let's go to questions, and we can come back to this if you guys want. This is how they ask these questions. All right. So what's wrong with the person? Yep, it's a motor issue. That's true. Okay, so weakness of right hand. So where do you think the problem would be? It's a thought, but you know it can't be the cortical spinal tract. Why do you know it can't be the cortical spinal tract? I should preface this: all of these questions Amboss considers to be like 4 out of 5 stars difficulty, or high, like 4 or 5. There's a couple out of 3s, but any of these track questions they consider to be very hard questions. Just so you guys like, I don't know, just to put it in perspective. But you know it can't be the cortical spinal tract. Why? Sure. I was gonna go with he walked into your office. He's not in a wheelchair, right? If the tract was damaged, you'd lose everything under it. It wouldn't just be in one hand. So you know it has to be a focal lesion, right? So we can rule out most of these real quick, right? So you know it can't be, you know it's nothing here. You know it's nothing here. Dorsal, it's not the dorsal column because pinprick and vibration is normal. You know it's not here because that doesn't make sense. It already crossed. If it's on the right side, it has to be a right-sided problem, right? If we're talking about motor, right? Because it crosses above this. It just told you that we're in C6, right? So it can't be any of these. Dude's not in a wheelchair, so you know it's not H. So really, that leaves G and F. So now the question is, do you know the difference between the parts of the ventral horn, right? I'm not going to fault any of you for saying F because you probably haven't looked at this. But it is G, right? Because it comes out this way. The nerves come out this way, right? So the answer is G. It's the dorsolateral column of the anterior horn. Also the ventral horn, right? In the door, out the vent. Yeah. They'll talk about ALS. When you guys get to those diseases, I'll give you like really super easy ways to figure those out. But you don't need to know any of these syndromes. You don't need to know any of this stuff, right? You could rule out all of these right away just based off of the things that the patient is doing. If they don't tell you the patient's not in a wheelchair, or if they don't tell you the patient's in a wheelchair, they're not in a wheelchair, right? So you can rule out so many answers by just thinking like, oh, well, this person would be paralyzed, or oh, this would happen, or they wouldn't be able to feel pain, or they wouldn't be able to feel vibration. If they don't explicitly mention the symptoms of the stem, they don't have them. You can rule out those tracks. So the real question was, did you know if it came this way or this way? Okay, so C6 is a dermatome. You're correct. However, the cortical spinal tract contains all of the nerves that are moving downward also. So if you lesion a tract, the damage is from the lesion and below. If you injure focally, locally the horn or the nerves coming in or out directly, then that's how you have a dermatomal lesion. So yeah, right. So the nerves come out like this. So if you cut here or damage here, it's just, and this is C6, it's just C6. If you hit here, it's C6. Oh, that's a terrible color. It's C6 and below. Make sense? Of course. Don't should be pretty easy. All right, where is it? Where's pain and temperature going? Yep, spinothalamic. You say it's F. F is a spinothalamic tract, but is it the right one? It is C. It is C, right? Pain and temperature cross early, right? So you're talking about the tracts? So it should be contralateral. So pain and temperature comes in, crosses the side. So if you're talking about the right side, it should be on the patient's left. I don't know if you want to like argue like, oh, well, they said upper versus down, but like, no, that's just how it is, right? It's just, it crosses early. Now, if they said motor or vibration proprioception, then it would have been ipsilateral to where they were poking you, right? Anything under the brainstem. But since it's pain and temperature, it's contralateral. Oh, I love this question. Why E? Yep, there's lateral horns. 100% it's E. Yep. You don't need any of this. You literally don't need any of this. They literally just could have said, where is this? Right? It's the only, that was the only option that was thoracic. They love doing this. They give you a bunch of useless information. And really all you need to do is say, oh, there's a lateral horn. Right? Now, you can argue that like, oh, well, the reason he's having these like weird symptoms, right? I mean, there's not really a lot of weird symptoms, but the reason why is like if let's like you could say like they could give you a patient who like his respiratory was all over the place and like pulse and blood pressure were all over the place. And like, oh well, that makes sense because it's like the autonomic part, but like yeah, just the lateral horn. That's it. Just an anatomy question. This is very typical of a brainstem question. All right, first of all, where are we in the brainstem? And how do you know? I think we're in the medulla. Why do you say medulla? Oh, does it tell you in the question? Oh, it does. Oh, my bad. Okay. The olives. You're looking at the olives, right? I know I told you in the question. My bad. But yeah, you can see the olives here, right? Okay, so how should you answer this question? It's exactly correct. Cranial nerve 12 damage, right? So this is 10. I think that's 10. That's probably 10. Yeah, that is 10. And this is 12, right? Great. Damage, the cranial nerve damage will always be on the same side. So they tell you that where is it? 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 Tongue, which direction does it go? It goes left, right? Left. Left one protruded, right? So you know that the damage is on this side. And cranial nerve 12 runs like this. So the damage is probably right here. Right. Right. And it's kind of this is why it's important to know the difference between the rostral and the caudal medulla, because they tell you that you're in the medulla, but they don't tell you that you're in the rostral medulla. You have to figure that out yourself. Because if you're in the caudal medulla, then the muscle strength would flip, right? Well, it hasn't crossed yet. So you have contralateral signs. Whereas if the lesion was in the caudal medulla, you could have ipsilateral signs. This would cross. And yeah, so this is I was just showing this, right? So this is you have the vagus nerve. And then this is the hypoglossal nerve, right? What does the hypoglossal nerve do? Stimulates the dorsal nerve. Fourth ventricle. Don't forget this. This is so important. A lot of times, you'll have they'll give you like a mass here, actually, and they'll tell you that the kid like has it's usually in kids. They'll have a mass here and have like tongue deviation. But then he'll also start to like be developing hydrocephalus because you'll be obstructing the fourth ventricle. It'll be growing into the fourth ventricle. It'll be obstructing the cerebral aqueduct, which connects up there in the fourth ventricle. It was kind of hard to see, so I redrew the arrow. Yep, that's correct. Yep, this is the graciculus, right? Gracilis, whatever it's. I'm not just trying to add vowels, but yeah, G for ground. It's in the middle. It's a dorsal column science. Oh, did you guys learn this yet? You guys might not learn this yet. No, this is about MILF syndrome, MLF. Okay, that's fine. Sorry, I meant to delete this one out. My apologies. You're gonna learn about it's the medial longitudinal folliculus. Basically, how your eyes actually work is when your left eye looks to the left, it tells the right eye to follow it. And this is like a derangement in that. You guys will learn about this. But this is yeah. Sorry about that. I meant to delete that out. That's very interesting. I'm going to try to be the one to help tutor you guys on that one because that gets a little bit weedy. The A. Why A? All right, I love it. All right, so Alex is right. All right, so first of all, this is syringomyelia, right? Sensation over the upper extremities and upper chest, right? Cape-like distribution. She keeps burning herself because she can't feel pain and temperature. Syringomyelia. So, did I put it in here? No, I didn't. That's unfortunate. So if you remember, in syringomyelia, it's the central canal, right, of the spinal cord that is terrible. Forgive me. Getting bigger. So as it gets bigger, it's going to take everything out with it, moving outwards. As it moves further and further out, you lose more and more and more. So you get drooping the eyelid. This is you get Horner. It causes Horner syndrome, basically, is what happens. And it's because those tracks are kind of close to the middle, right? So you get lower motor neuron injuries where the damage is. And if you remember, we said before that it was like it's usually in the cervical region, right? So you'll get lower motor injuries there, and you'll have upper motor injuries below it. So if this would have said decreased biceps reflex, that would have been a correct answer. Because you would have a lower motor neuron injury at that region. You would not have an upper motor neuron injury. Right, because C5, C6, right? C5 is biceps, C6 is wrists. Yes and no. Yes and no. The anterior cord goes first, but after a while, you just continuously lose everything moving outwards. It's not really like quote spared. I'm 99% sure. But you usually don't have to worry about it in questions because I don't think I've ever seen a syringomyelio question that wasn't like Cape distribution, pain and temperature deficit. Yeah, I mean, I can look into it actually. I can look it up for you, and I can get back to you on that. But I'm pretty sure the dorsal column also goes. Like I'm 99% sure the dorsal column also goes as it expands outward. Yeah, it looks like they're spared until like really late stages. All right, how about this? Dorsal root. Okay. So stabbed at T9. Okay. So you're saying he stabbed here essentially. But if you look at the question, talking about his toe, right? So this would be a focal loss in T9 of really pain and temperature, right? Because it's this dorsal root. It doesn't say dorsal column. It's dorsal root. You're very much on the right track, right? It is a dorsal column problem. It's just not an answer, right? But the posterior spinal artery is, right? So that's the only one of these answers that's going to give you dorsal column signs, right? Because this doesn't make any sense at all. This is obviously not true. For those of you who don't know what this is, and I'm assuming that's all of you because I didn't know what it was until I saw it in a question. This causes anterior cord syndrome. It's like down in like your pelvis. So it's posterior spinal artery. Does this make sense? Why it was posterior spinal artery and not dorsal root?
Just go over it one more time, please.
No problem. No problem. Okay. So the dorsal root is the DRG, which is here. It's like it's the sensory information coming in. The dorsal column is what was affected. The dorsal root carries pain and temperature sensation in, right? And then they come in and then they cross the anterior commissure and then they go up the spinal thalamic tract. But this person got stabbed in the back and he lost position of vibration sensation all the way down his toes. So you would have had to have hit something, one of the tracts, right? So you need something that hits the dorsal column. And the blood supply for the dorsal column is the posterior spinal arteries, and there are 2 of them. So you don't get complete dorsal column signs. You only get like ipsilateral dorsal column signs. Whereas in the front, if you were to get stabbed in the somehow in the ASA, usually during surgery, actually, if they're asking these questions, usually during surgery, if you nick the ASA, then you get complete anterior cord signs. It's not unilateral, but the dorsal column, it can be unilateral because you have 2 posterior spinal arteries. Does this make sense? Awesome, cool. Cool. All right, what happened to this kid? What is he losing? No, it is not a lower motor neuron lesion. Why is it not a lower motor neuron lesion? Here's the track. And in the spinal cord, these are getting worse and worse. I'm sorry. Oh, what did I do? I don't want to do that. Undo. Yeah, it is E. It is E, right? But the reason it's not tracks is because the tracks come down, right? And then they come out here. And they synapse here. The tracks inner, and they synapse here. And then these. Color. Right? So the track comes in and it synapses on this neuron. This is the last motor neuron. If you damage this neuron, that's a lower motor neuron injury. If you damage the tract, that's an upper motor neuron injury. That makes sense? You can only have a lower motor neuron injury if it's the last nerve. It has to be the nerve directly innervating the thing you're talking about. So yes, the answer is E. What if it said damage to the ventral horn where it synapses? Well, you'd have to assume if you're going to damage the whole ventral horn, you'd be taking out the axon body of the terminal neuron. So that'd be a lower motor neuron injury. Yeah, that usually when they want you to think lower motor neuron injury, they say ventral horn. They'll either say ventral horn or they'll say you know what? To be completely honest with you, they pretty much only ask about upper motor neuron injuries now that I'm thinking about it. The only if they if they are asking about a lower motor neuron injury, they're going to describe the symptoms, and then you have to say it's a lower motor neuron injury, or you'll have to say like damage to the ventral horn, or something like that. But yeah, it would be that would be your lower motor neuron injury. But yeah, because it's the tract, you lose motor function below, right? At the lesion or below, you're damaging a tract. Where's my going? Draw. You're damaging a tract. So it's lesion, T1, and below. That's fine. I kind of gave this one away already. Yep, it's B. Right. They're doing surgery. They accidentally nick the anterior spinal artery. Now you have anterior cord syndrome. This is a very common way for them to ask about anterior cord syndrome. Is they'll to say that this person had like a procedure, either an abdominal aneurysm repair. This one says thoracic. A lot of times it'll say abdominal. It'll be abdominal aneurysm, but surgery. They'll be doing surgery. They'll nick the anterior cerebral or anterior spinal artery, and then the person gets an anterior cord signs. All right, this is it. This is the last question. So I don't know what you guys want to do. If you guys want, I can go back and I can go over some of the more spinal tract things. And we can talk about a little bit like of brainstem lesions if you really want. But it's really hard to do the brainstem things without all of the like cortical and cranial nerve things. Because to be honest with you, the brainstem questions, you should just cranial nerve ipsilateral. That's the answer. So like tongue deviation to the left pica. Or no, ASA, I'm sorry. Typing. So when you say major depression and persistent depression, do you mean dysthymia, like persistent depression disorder? Oh, yeah, I guess that's probably what you're talking about. Okay, so with major depressive disorder, you have 5 symptoms. With persistent depression, you have 2 symptoms. That's it. If you want, like that's basically it. Dysthymia is kind of like depression light, but it goes on for like a super long time. I think dysthymia it needs to be 2 years, whereas depression you only need 6 months or a year. I think it's one of the 6 months. You only need 6 months, but you need 5 SIGI caps for depression, and you only need 2 for dysthymia. Of course, of course. If anybody has any questions or anything, or need me to explain something again or expound upon something, please. Well, you still got me. So I did not post these slides mainly because I would basically just be plagiarizing from AMPOS, so I can't post them on Canvas. But I can send you the PowerPoint if you want me to. As far as next week, I can host sessions about anything you guys want me to because I am also a peer tutor, and I can also do supplemental course tutoring. But I don't think I'm the course tutor again until the eye stuff because I specifically requested to do the eye stuff because I know it's like really complicated. But if you guys just let me know, I can hop back and do basically anything. But you guys will have course tutoring for BAB every Tuesday and Thursday. But I do plan on doing a pre-exam review for both exams. So probably not the final. We'll see. You just probably won't need one for the final. All right, y'all. Thanks for coming. I hope it was helpful. Talk to
Hey,
you
can
later.
you go to the MLF question for me?
Yeah.
Is it D?